All right, so it's the anterior aspect of the shoulder. First thing to feel for is that coracoid, so you can feel the coracoid deep in there. I usually go about a finger breadth lateral to it. And again, we're aimed down to where the medial edge of the brachioradialis would be, so I have an inline incision just below the axilla. So probably something like that. So again, palpate that. Coracoid, full thickness flap right here. I'm going to go a little longer than usual just in case. You can see making the full thickness flaps starting right there. Cephalic veins in your view. And there's that fatty intral right there that I usually find to find the cephalic vein. For this specimen, we'll keep the vein lateral. I'll spend some retractors there in a second. Perfect. Again, keeping cephalic vein lateral in this case. That's where it wants to be. And I'm a finger dissector, blunt dissection to open that up. And bring it up to the top right there. And that's great. So now we got under the pec here, clear up under the pec, clear up under the deltoid. I find I clear up a lot of the scar tissue on the deltoid. It helps with mobilization of the humeral head later. Pop that under the subscap, under the pec, under the deltoid, and then you have your deltoid full opened up. On this view, you can see the coracoid tip with the conjoint tendon running down. You can see actually as I rotate the arm around, you can see the pec insertion right there with the long-headed biceps right underneath. And then as I reach over, we're going to free up just into the subdeltoid space. You can see the CA ligament right there too, which will open up the subacromial and subconjoint space in a second. As we open up, free up the clavictoral fascia right there. We're going to free up underneath the conjoint tendon a little bit. Won't go too deep for vascular and nerve supply there. But as I open up underneath the CA ligament as well, free up some of that fat. Get my finger underneath the CA ligament, feel for intact or non-intact rotator cuff. That's perfect. I'm going to readjust my retractor underneath the conjoint tendon so you can see the subscap. And then as we have that, you can actually see the anterior humeral circumflex arteries and veins right at the bottom right there. So I usually ligate those. Once those are ligated, we can internally rotate the arm a bit, and I'm going to expose the biceps. So I tenodesis off every case. So for this, just going to bring this up and then bring it up in the wound. Usually you can have a retractor sitting up high as well right there to open things up. But once you've freed up the long head of biceps, you can tenodesis it. Wherever you want to tenodesis it, I actually prefer to tenodesis it to the transverse ligament up high here. Most people try to do a tenodesis to the pec, upper pec right there. They can get the biceps out of the way. For this case, we're going to do a peel of the subscap. So what we're going to do is we're going to release the subscapularis right off going here. I like to see the biceps first so I can see where we are. Right into the interval right there. And so we'll just release with blade right off bone. Again, into the interval. I try and maintain the CA ligament through all cases, but in a reverse, I don't mind if I have to take it, but if I can maintain it, I will. And then I usually stick in a retractor into the wound, so I might still one more time here with your other hand. So once I can open up and see the space, I'll tag the subscapularis for later repair at the end. So if I'm using a stemless design, I usually do a tenotomy. When I'm doing a stem design, I usually do a peel, or if I need extra length for rotation. Awesome. So peel off all that capsule, peel off the subscap inferiorly. And then once that's all cleared off, right down the pipe, I'm just going to see if I can peel around the side. And you can dislocate the head. I still have a little bit of capsule down there. So again, to help with your subluxation of your humeral head later, and peel that off. Great. So once that's all done, we can dislocate the head. So you can see the biceps right there, but intact cuff up top right there. And slide this over the top right here. So yeah, once you have that exposed, you can see on this model, there's no bone left right here, a little cartilage left right here. The lesser tuberosity is nice and empty. And there are some osteophytes. So if you can, before you start going crazy, take down some of these osteophytes with your rongeur. So took those down. Often I'll do that before I actually set the head and dislocate. This will help you find your natural version. If you're going to do a freehand cut, we'll show you kind of the guided cut. You can take off some more of this soft tissue capsule at the bottom right here. You see right under. The more of these osteophytes you take off, the more accurate I think your cuts can be. Also help you with impingement later and access to the glenoid later. So the more you can do now, the better. This guide is essentially going to give us a 135-degree head neck angle and about 30 degrees of retroversion if we line this up with the forearm right there. I'm going to maintain this. Try and keep it close to their natural version, but this will set him or her at about 30 degrees of the retroversion, inclination of about 125 or 135. You can also do it freehand as I was saying before. We set the guide so that we can avoid cutting into the insertion of the subscapularis as well as the supraspinatus tendons. An oscillating saw is normally used at this portion. We want to place the humeral sizer to fit just within the cortical rim. We don't want it too big or too small. Pop this in place and then we will get onto the reaming. So you have this flush on your crux and you can feel the cortex pop through there, bicortical, and pull this guy back. And we're going to ream, pop it on there. Mouse it down as it come up. You have a nice donut there, or a ring. I'm going to guide this just above the bicipital groove is where I want my arrow. So I'm going to pop that right there. Try and get centered in that defect right about there. And I'm going to get the, I'll get the little guy for this one. Majority of the time it actually goes in where you have a bite. You can see I can pull on that, move the whole humerus, so it actually has a good bite there. And rotate that out. Take this out with our driver. And then we are going, in case you're doing a reverse, we're going to use our double pronged device here to see what our final version was, as well as to see what the bone quality is as we tap it down. If you're using a short stem, this is a size larger, you're going to go to the second last line for this guy. Here I can just see what my final implant's going to look like, so it'll sit up a little bit at the edge right there. But everything else looks perfect. If I line this up with our forearm, you can see it's still set at 30 degrees like our cut was. And that's it. So kind of preparation for the stem if we use a stemmed implant. Then I got to top that back down. And then we're going to move to the glenoid. Here's the upshot of the glenoid. We're going to the glenoid there. We're going to incise some of the capsule just at the anterior aspect of the glenoid. You can see I've got some stuff in there. We're going to take away all the labrum there. And there's actually a little cartilage left here and down the bone here. So we'll remove that cartilage in a second as well. So first off, I'm going to remove the cartilage. And again, you can use an osteotome for this tool. I'm going to use my rongeur again, so it slides under nicely. Once all the cartilage is off bone there, you can see this biconcavity there. I'm going to take off some of the inferior labrum. I do a circumferential release. I release the triceps tendon origin at the bottom here. In this model, you can see how close the axillary nerve runs the inferior aspect of the glenoid, so make sure you are careful with your retractors. I'm going to take out the biceps origin as well and do a circumferential release, so now we're flush on bone right there. And then usually you're going to have to take away some of the capsule between the subscap and the labrum and the anterior glenoid, so we're going to cut some of that stuff here. And as I'm cutting down again towards that axillary nerve, we're going to stay right on bone. We're going to take away the triceps origin, worried about that inferior aspect of the glenoid tubercle, or inferior glenoid tubercle. So we're going to correct some version. This patient has 18 degrees of retroversion, and we'll set it, we're going to correct down some of the version down. So we'll stick the augmented aspect at the back, and then we're going to ream down the high side to almost have a inlay onlace from front back. This device here, you can see there's a little augment at the back here. We have it set to almost correcting 20 degrees there. So as we sit at the back, I can feel it. Here's the bottom of the glenoid right there. So you can get a sense we're sitting right in the middle of the glenoid. Pop that sucker in. We've already got the correction of almost 20 degrees. And off this, you can actually feel the back cortical wall. So we can see we're sitting at almost 30 millimeters. So if we were doing a reverse, we'd put in a 30 millimeter, actually almost 35 ventral screws. And once that's in, you can leave that in there. We'll pull this back out. And now that's set for the correction of almost 20 degrees. at the back here, that's to correct that version. I'm gonna pop that back out, that was perfect. And then with this guy, I'm gonna pop that in here, again, cannulated, hold on to that drill bit. And I go down to we have about 90% contact in this. So as I ring down, you can see, I'm gonna pull it back for a second, you can see we're starting to get the front half of 50% contact there with the donut. We're gonna ring down more, basically getting into subchondral bone. So right there, you can still see part of the donut there. I'm gonna remove some of that soft tissue, but everything's looking good. So what I'm gonna do is stop right there and get a trial in there to see if it's stable. So as I take away that bone, you can actually see we've drilled circumferentially that inner donut or inner circle. And so we should have a good stability with that. And as I place this down in place, that's the implant right there. You can see there's no rocking. So it's sitting onlay at the back, posteriorly, and inlay at the front. It's actually very nice and stable. Like a trial when it has such significant deformity. Again, we corrected a lot of it. Sometimes you have to take a little bit of the bone around the front or anterior aspect off. But otherwise, we'll take that out. When you cement it, I just use a little syringe cement technique. You cement inside. Once it gets a little bit hardened, you can actually stick it in the sides. It doesn't drip all over. Pack it in, keep it just in there. And then you can insert your final implant. So this is the all poly unit. You can see the center ring is going to be cemented. That's bone that's going to grow onto that. And then we're going to pop that in there. Once it's in a little bit, you actually move out of the way, and then we're going to melt the rest there. You can see it's still sitting up. So we're going to hit that in place. Once it's in, you can see no rock moving back and forth. I can push this on the load end right there. You can see that's how it's onlay right there. And if you needed to, you trim the osteophytes on the front. So that's your anatomic venoid, and then you go back to the humerus. So we're going to take some of these out. Now we'll do a trial of the head first. So we get this guy out right there. I'll bring the head back into that position. And then I will make sure that's still stable. So honestly, after that, that's pushing and pulling. Yeah, that'd be awesome. We tend to check the blazer to make sure it's still intact and stable. And this still is, even though we put it through a lot. The head trial, again, we want it to go just under the rotator cuff. So we're going to move that out of the way. We're going to impact that if needed. And we're going to rotate that in. So we're going to take that back out and keep that view right there. But essentially, we want to make sure it can shuck 50% of the way back and it pops back in. I want to make sure I can fix the subscapularis about 40 degrees of extra rotation. And with 6 degrees of rotation, it's not impinging. So you can put this through a little bit of a range of motion. Sometimes you just get an army navy and it's too much, but you can see it's nicely subluxing, nice and smooth. If it's too tight, you can change the size of the head, the depth of the head. But yeah, that's everything right there. And the next step would be to put in your stemless. So we'll take this off with the tuning fork there. Tuning fork's coming out, so there you can see that's still in there. And it comes straight out, so you can still see you have the nice star shape in there. You're gonna put your final implant with. So again, final implant, this is your final implant right there. It's a size large stemless. It screws onto this if you get the right angle. And then you can see the back, 3D printed. Basically bone grows into it. If you need to pass sutures, you can pass them through the ring. And essentially you've already set this up. Just gonna take that rotator cuff out of the way, make sure it doesn't sit underneath. It's gonna sit just in bone right there. Still feel like I'm sitting a tiny bit high. In real life, you actually leave it a tiny bit high and you impact the rest of your head. I'm just gonna see if I can get a little curve in there. And then you can see I can actually pull this on the bone. Nice foot there. And then we'll put on the final head. So this is the final head. I'm gonna put that in place just so we can actually get these apart later. We won't fully impact it, but that's gonna be what it looks like right there. So you would impact it. I do 7 times because I like the number 7. And then we're going to release it. So I'm going to keep going right there, pop this back out right there. And then when we pop this in, this head's a little bigger than our trial, so it's sitting a little tighter. But you can still see I can mobilize it and move it wherever I need to. So that's good, and that's your anatomic. So then if we needed to do a reverse, the cuts are all the exact same for this procedure or for this implant, so that makes it a little easier for us. What we're gonna do is we're gonna take off this head again with the tuning fork. Hopefully we didn't impact it too much. That would make it easy. And then rather than wait, we'll show you what the final stem looks like. We'll take out this blue, the stemless design here, so he gets in place right there. So again, back tap this. Fantastic. And so here again is what we're left with there. When you're doing your final route for the reverse and for any stem implant for an anatomic, this would be what the setup looks like here. So again, you're going to use that same tune that you had those the double prongs impactor at the beginning. Again, we're going to line that up at 30 degrees. You want to make sure you don't fall into varus or valgus. You want to go straight down the lateral aspect of that humerus. Lateral, again, you're going to move that cuff a little. You got very good cuff still. And it's going to sit flush the bone and get rid of some of those osteophytes there. But again, good bone, not coming out, feels nice. Now, to get this implant up that's well in there, I'm going to see if I can pop it out the back without wrecking it. So we're just going to work our way, it's slowly loosening up. So usually you just do the lever on that, take out the cement. That's what we're left with right here. Again, if you wanted to ream down a little more, you could, but I'm going to leave that here knowing that this was stable. The file implants are the medically used the same size, so that was a size large, so we can use a large medically as well. So if you're even revising for this one, whether you have a large or extra large, you can use a size large. Rotate it around the bottom screw there, I like at about 6 o'clock. And your implants, and usually I'll give it a little pull back. You can pull the whole glenoid. And then here you can see everything seating down. Each of these screw holes are actually sitting flush, but if one of them was up, you can use an augment there as well. Central screws going to go in as compression screws, so we've already measured that off the last when we initially drilled at that 30 or 35. And you can go in all the way flush. And you can see it's such good bite. You can see the whole scapula moving right there. So you can always test to make sure it's flush. We'll do that at the end. But basically we're going to do 3 peripheral holes. Again, with a full reverse, I probably would have been a tiny bit more inferiorly as my initial plan. I drill all 3 at first. This is so far, nice long screw, we're going to be about 40, 45. And 15. Perfect, that's a nice 35 as well. All right, so then you finish it off. These are all lock-in screws peripheral, so they all better have good bite. And that's it. So now that's nice and solid. You can see everything's in there. We do want to check centrally to make sure that central screws all the way down so you can see that's flush. But once it's all flush, you can see we still had some room to go. So if this was, again, a reverse I was doing primarily, would be a little lower. So we can use an eccentric. So basically the first one we're going to put in is non-eccentric. You can see it's sitting right in the middle. We're not quite at the bottom, so it'd be nice to have it a little further. Sometimes there's one big, larger size, but that's what the non-eccentric will look like. So here's the eccentricity. So if we pop this at the top right there, and you can actually cover that bone that's missing. So right here now you can see inferiorly, when we said it before, you can see it's now popped off the side there. So that's what that would look like. We'll just show you the trial. So it would be a nice metal ball. I'll show you what it looked like. So basically that would pop in the front and the back, and you'd screw that in, and that's going to sit right there, and we're going to couple those together. So as I hold that lateral, pop it in, you can see it's sitting nicely, has good rotation. Once that's done, final liner, final glenosphere, and then you're done.